You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for August 29th, 2025. I'm recording in Madrid, Spain. I am at the ESC meeting. Today's podcast will be a little longer because we have really exciting news from ESC. Other things that I'll discuss today are that the CAC0 people take a gut punch. ICD Therapies cannot be surrogates for benefit. And boy, is ESC really getting good. And I'll have two reports of two important trials on the first day. But let's start and talk about coronary artery calcium and a recent study from Denmark. Now, proponents of coronary artery calcium scans suggest that the scans can enhance risk stratification. Specifically, the scans enhance risk estimates over and above the pooled cohort equation. The PCE equation calculates, it estimates 10-year risk for a cardiac event. For instance, your 10-year risk could be 5%, 7%, 15%. And while these numbers seem quantitative and impressive, the truth is that patients and doctors alike inherently sense heart disease risk. For instance, if you are old or have high cholesterol or hypertension or diabetes or smoking, you're going to have a high risk. So enter coronary artery calcium scans, CAC scans. While proponents will emphasize two outcomes from coronary artery screening, A, the scan could return a very high calcium score, and this will increase 10-year risk, and then that will strengthen the case for taking statins and other preventive therapies. Or B, the CAC scan may return a coronary calcium score of 0, and here observational studies show a low risk of events that may decrease the case for taking preventive therapies. You can imagine a scenario where a 50-year-old person does not want to take statins, but this person has a 10-year risk calculated at 7.6%, above the threshold for recommending statins. Now, if this person has a CAC score of 0, that risk goes down, and voila, he does not need to take statins. Now, I haven't even got to the study yet, but I hope you can see the folly in these calculations, as if a 7.6% 10-year risk is any different from a 7.4% risk just because one is over the threshold of 7.5%. Now, my problem with this power of zero thinking has always been this, that RCT after RCT have shown that statins reduce the risk of a future cardiac event, no matter the baseline risk. Now, the risk goes down by 25% in relative terms, whether you start at a 5% risk or a 15% risk, and this data is clear. Now, proponents now say that since observational studies correlate a CAC0 with lower rates of events, that statins can be withheld. And I get that thinking, but taking that logic to its end means that observational studies are ranking higher in the evidence pyramid than RCTs, and that does not compute in my brain. So now, a recent study from the Western Denmark folks strengthens my case against CAC. Just one more fact before I finally get to the study. Now, plaque can be calcified or it can be non-calcified. The scans only pick up calcified plaque. All right, now to the study. This was a cohort study from Western Denmark, and it included 24,000 people who had a CCTA done for symptoms and ended up having a CAC score of 0. The years of the study were 2008 to 2021, and they had a median of 7 years of follow-up. The question from this observational study was to calculate the odds for having a non-calcified plaque and then cardiac event in patients who had CAC0. So the prevalence of non-calcified plaques overall was 11%. Now imagine 5 categories of LDL cholesterol and 5 categories of LDL cholesterol in different age categories. The authors now just correlate the presence of any plaque and non-calcified plaque. They then correlate the odds ratio of having an event based on the LDL cholesterol. Recall that all these patients had a CAC 0 and enough symptoms to get an initial CCTA. Those authors calculated odds ratios based on 1 millimole per liter higher LDL cholesterol levels. Now, 1 millimole is about 38 milligrams per deciliter. The overall adjusted odds ratio for non-calcified plaques in these patients was 1.21, and that was highly statistically significant. Now, the corresponding values based on age showed a gradient. The odds ratio was 1.39 higher at ages less than 45 years, 1.22 for 45 to 60, and 1.11 for over age 60. Now they did correlations with coronary heart disease events, and they had only 1% in the total cohort. Now, per 1 millimole per liter higher LDL cholesterol, the average adjusted hazard ratio was 1.28 for coronary heart disease, and there was again an age gradient. The hazard ratio was 1.37 for young adults less than age 45, 1.24 for 45 to 60, and 1.26 for age greater than 60. The authors concluded that, quote, in symptomatic individuals with a CAC of 0, elevated LDL cholesterol associated with higher risk of non-calcified plaque and with a higher relative risk of future coronary events, most pronounced at age less than 45 years. This indicates that LDL cholesterol control over a long-term horizon remains important in younger individuals despite having a CAC of 0. Now, my comments. The age part of this finding in this study is most notable, I think. The risk of having a non-calcified plaque and an event among these CAC 0 patients was greatest at a young age. In other words, the power of 0 is less at younger ages, and the power of LDL cholesterol was greater at younger ages. But, younger ages is where prevention is most valuable, i.e., if you avoid a deadly MI at age 40, you gain a lot more life than avoiding an MI at age 80. The age gradient of risk makes intuitive sense based on the very old school understanding of the atherosclerotic process, and I hesitate to go through this, but I think it's worth going through this old school thinking. Namely, that atherosclerosis begins at a young age and starts with these young, thin-walled, more friable plaques. Grows slowly over time, that plaque matures and becomes more stable and calcified. This is why you get asked on cardiology boards which lesion is most likely to cause plaque rupture or occlusive MI, a non-calcified 10% obstructive lesion or a calcified 90% lesion. The answer is that the less obstructive lesion is more likely to cause MI, and the calcified lesion is more likely to cause angina. And of course, this is why a negative stress test does not preclude having an MI the next day. 10% lesions don't cause ischemia. And this observation is why every RCT ever done shows that PCI and revascularization does not reduce MI over medical therapy, no matter how gnarly the angiogram looks. The stents target the obstructive lesions, and the MIs come from the barely noticeable stenoses. Medical therapy targets all the disease. Now, the findings from this Western Denmark study should make you question the power of 0. In this well-done observational study using Danish registry data, which is quite reliable, they find that patients with a CAC 0 who have high LDL cholesterol before the scan have a higher risk of non-calcified, presumably younger plaque, and a higher rate of coronary heart disease events. It provides a reason, I think, for patients interested in prevention to take preventive measures such as lifestyle interventions and statins. Now consider a 50-year-old man whose PCE is mostly driven by a high LDL cholesterol. For instance, this patient doesn't have hypertension or diabetes or smoking. He just has a bad LDL cholesterol. Let's say his risk is about 8%, but his CAC score is 0. Advocates of the CAC power of 0 say, no worries, you have a high LDL, but you can avoid statins. Well, this study says, wait, the risk is elevated versus those with a CAC of 0 and a normal LDL cholesterol, you should probably take a statin. So my most common argument against using these CAC scans is that a higher number that increases risk over the PCE hardly helps much. Risk is risk, whether it's 5%, 7%, or 15%. A person who wants to max out preventive measures, wants to do everything they can to reduce their risk of having an MI, they don't need a CAC scan. They just take the statin. For minimizer patients like myself who believe in the stochastic nature of disease, I can't contextualize a risk of 5, 7, or 10% over a decade. What does that mean? A CAC score hardly helps in this regard. So this is an argument I call people can't digest different risk over 10 years. That's one argument against CAC scores. But this study hits the negative predictive value side of the CAC argument. If CAC 0 was actually akin to an inoculation against having heart disease, then it might be value in knowing the score. But now, for the millions of people who have a CAC score of 0 and a high LDL cholesterol, this Danish observational study is that the CAC 0 is less protective than we might have thought it to be. And it was most pronounced in younger adults. But the pattern was also there in older middle-aged adults. Now finally, I went on for minutes without saying that CAC should not trigger a stress test or angiogram. That thinking fails Cardiology 101, but sadly it is the prevailing opinion in my zip code and maybe yours too. Okay, next topic is assessing ICD benefit in the modern era. Now, like the post-MI beta blocker studies featured at ESC, the ICD also is going to need a relook of new evidence. The seminal ICD trials Scott Heft and Made It To enrolled patients more than 25 years ago. The last large ICD trial, Danish, published in 2016, returned no results of the ICD versus background therapy in patients with heart failure not due to coronary artery disease. In 2017, heart failure trialists have published an important paper finding that the rate of sudden death, that which is prevented by an ICD in trials of patients of HFrEF, have fallen over the course of time. That paper is by Shen et al. All of these facts have led brave European investigators such as Gerd Hendricks and Nicolas Dagres to launch the PROFIT trial of ICD versus no ICD in ischemic cardiomyopathy. PROFIT is trying to replicate Made It To with background medical therapy in the modern era. Recently, Jack has published a new observational registry study which assessed time to first therapy in contemporary ICD patients, the point of which is to infer the proportion of appropriate therapies based on the adjudicated subset of randomly selected episodes. Now, I know that was a lot to say. Basically, these authors did a query of the Medtronic CareLink database from 2013 to 2024. First-time Medtronic ICD recipients implanted with a single or dual-chamber ICD were included. They then generated cumulative incidence functions for time to first shock therapy, anti-tachycardia pacing, and any therapy, shock or ATP. And then 3 trained observers analyzed nearly 600 randomly selected episodes to manually assess whether the therapy was appropriate. Now, they now had enough information to model appropriate therapy in the rest of the huge database of 230,000 patients. And they found the cumulative incidence of 3 outcomes: first appropriate shock, ATP, or any appropriate therapy was 33%, 42%, and 48% at 10 years. Secondary prevention ICD-indicated patients had a higher 10-year cumulative incidence of first appropriate shock. It was 41% versus 32%. The authors concluded, quote, nearly half of contemporary patients receive appropriate ICD therapy by 10 years post-implant. These data indicate continued benefit of ICD therapy despite modern refinements to device management and medical and interventional cardiac care. Now, even more provocative than this conclusion is the third paragraph of the discussion section where the authors write that multiple reports suggest underutilization of ICD in eligible patients, and they write, quote, "This underutilization may partially stem from an impression that ICDs rarely are called upon to treat spontaneous ventricular arrhythmias." So my comments. Now, I mean no disrespect to the author, some of whom I know and respect, but I strongly disagree with their conclusions from this observational modeling study. There are two huge assumptions in this study. A, that therapy equates to lives saved, and B, that adjudicating a small number of therapies inoculates the analysis against counting inappropriate shocks. Now, we have known for years that an ICD therapy for VT does not necessarily mean the patient would have died without it. You don't know what would have happened the second or half second after a shock or ATP stops a VT. That VT may have self-terminated. In fact, the MADE-IT RAT trial of permissive programming, that means less ICD intervention, actually improves survival. Now, the methods of this paper are reasonable. It's the conclusions that I think are the problem. It's fine to describe therapies in patients. We can learn things. But the only way to assess ICD benefit is to randomize against medical therapy. ICD therapies in uncontrolled studies can never be a marker of ICD benefit. So I also strongly object to the proposal that ICDs are underused. Chart review studies cannot sort out why patients with HFrEF may not have an ICD. I am often asked to consider an ICD in a patient who, on paper, has all the eligibility for the ICD, and within 2 nanoseconds of walking into the room, I understand why no one has suggested an ICD in that patient. I work at a busy U.S. hospital in a medium-sized city, and it is now rare that I implant a primary prevention ICD. These patients have almost disappeared, and thanks, I think, in large part to our interventional colleagues who stop the MI processes before it causes ischemic cardiomyopathy. I have another objection to this whole ICD underutilization thing. You cannot promote shared decision-making and underuse of any intervention in the same breath, for if there are truly shared decisions where therapy is aligned with the patient's goals, ICD use rates are not up to doctors, it's up to the patients who have been thoroughly informed. All right, let's move on to day 1 at ESC, and oh my gosh, what an exciting day. I'm recording this podcast in my hotel room on Friday morning. By the time it is released in the afternoon in the United States, the first day of ESC will have long concluded. We will know the results of the first few big trials. I won't have time for a detailed analysis because I've only seen the results for a few hours, but I can tell you some of the initial results. The first and perhaps most important trial of the meeting, perhaps the most important trial of the year, is the DIGIT-HF trial of digitoxin versus placebo in patients with HFrEF. The German-led trial took 8 years to finish. Low enrollment required longer follow-up. Now, digitoxin is a cardiac glycoside like digoxin, but it has additional enterohepatic clearance. This is an important thing because digitoxin is easier to use and leads to steadier levels in the ideal relatively low range. Patients in this trial were well managed on guideline-directed medical therapy. The trial had started before SGLT2 inhibitor trials were released, so only 1 in 5 patients were on SGLT2 inhibitors, but everything else was highly used. After a median follow-up of 3 years, a primary outcome event of all-cause death or first hospitalization for heart failure occurred in 39.5% of patients in the digitoxin group versus 44.1% in the placebo arm. That 4.6% absolute risk reduction, NNT equal to 22, translated to a statistically significant 18% relative risk reduction. The hazard ratio, 0.82, 95% confidence intervals, 0.69 to 0.98, p-value equal to 0.03. Both components contributed to the composite endpoint reduction. The hazard ratio for death was 0.86, and the hazard ratio for reduction of first heart failure hospitalization was 0.85. Subgroup analyses yielded a moderate signal for a heterogeneous treatment effect in which the benefit from digitoxin appeared strongest in patients with more advanced heart failure. Why do I say that? Because the effect size for digitoxin was greater in patients with systolic blood pressure less than 120 compared to greater than 120, and with heart rate greater than 75 versus less than 75. DIGIT-HF was a positive trial. Pause there for a second. We went from DIG is poison to DIG may become the fifth pillar of heart failure therapy. Before recording this podcast, I did do a written write-up for the DIGIT-HF trial. It'll be on the heart.org Medscape Cardiology. The title of the piece is called 5 Big Messages of the DIGIT-HF Trial. Please do take a look at that. Here is the summary. I don't want to give it all away. But lesson number 1 from DIGIT-HF. Now, the DIG is poison story stemmed from flawed observational studies where sicker patients get treated with DIG. This trial, as well as the DIG trial many years ago, find that when you balance patients through randomization, there is no harm signal from DIG. Now, 2 of the authors of the DIGIT-HF trial actually showed this prescription bias 6 years ago with a very clever analysis of the data from the DIG trial. I'm sorry to say that this European Heart Journal paper was largely ignored. The first author is Davila. Now, they had open data from the old DIG trial. About 40% of patients enrolled in the trial were already prescribed digoxin. About half of them were randomized to placebo. The authors were now able to compare the main randomized results of the DIG trial versus the non-random comparison of those pre-treated with DIG versus those not pre-treated with DIG. And what they found was that mortality was 22% higher and heart failure hospitalization was 47% higher in patients pre-treated with digoxin versus those not treated with digoxin, even after adjustment of baseline population differences. The higher risk for both outcomes in those who had been previously received digoxin persisted, even if they received placebo. Now, this sharply contradicted the neutral effect on mortality and the significant reduction in heart failure hospitalizations observed in the randomized comparison. And so that actually just simply proves that there's prescription bias. DIGIT heart failure trial confirmed that when cardiac glycosides are studied in RCTs, no harm is found. All right, lesson 2 from this trial is digitoxin exerted its positive effect on top of good baseline therapy, which is remarkable because GDMT for heart failure is pretty darn amazing. Lesson 3, digitoxin led to a 4.6% absolute risk reduction in all-cause mortality and heart failure hospitalization. That is similar to the SGLT2 trials. And you add to the calculus here that digitoxin cost almost nothing, and you get quickly to provocative questions of what to do in cost-constrained patients. Should digitoxin be the first drug, or DAPA or empagliflozin? The fourth lesson is that digitoxin is not digoxin. I think we have to be really careful translating this trial to healthcare systems where only digoxin is available, such as here in the U.S. Digoxin is renally excreted and is tougher to use. I would be careful translating these results in the carefully done environment of the DIGIT-HF trial to routine use in the U.S. where many patients have poor access to drug monitoring. There is a Dutch-led trial called Decision that is studying digoxin versus placebo in HFrEF patients, and results are expected next year. Lesson 5, I think, is the most provocative one, and I actually hate to bring it up, but it is the matter of statistical robustness. DIGIT-HF had slow enrollment and lower than expected event rates. You may have noticed when I told you the main results that the upper bound of the hazard ratio was 0.98, close to 1.0 or no effect. The p-value was 0.03. I put these results into a fragility index calculator, and the fragility index was actually 0, meaning that the results hover dangerously close to the arbitrary threshold of non-significance. What's more, 17 and 8 patients were lost to follow-up in the active versus placebo arms, respectively. When the number of events is so low, even this low amount of missingness can be important. As I wrote in my written piece this morning, I wish I could tell you how to resolve the concern that the findings in DIGIT-HF could be noise rather than signal, but I can't. The trial has made a great effort, and the fact is that small numbers of events often adds uncertainty. Now, I put the numbers from DIGIT-HF into my Bayesian transition worksheet. This is from Sanjay Kaul, and found that the probability of a primary endpoint benefit of more than 0 is high, about 90%, but the probability of a 15% improvement is 50-50. Still, though, I say completion of the DIGIT-HF trial fills me with optimism about evidence-based cardiology. I mean, neutral observers of DIG use in the seminal trials never had a negative view of that drug. That it fell out of favor, I think, was wrong think. All right, now digoxin is back in the conversation thanks to the DIGIT-HF team, and now my use of digoxin will look a lot less archaic to my colleagues in Louisville. All right, next trial at ESC is called the POTCAST trial. Not POD, but POTCAST trial. Christian Johns and his team in Copenhagen presented results of the POTCAST trial, which studied a novel potassium replacement intervention in patients with ICDs in an attempt to reduce ventricular arrhythmias. This thinking is as old as dirt. We know hypokalemia is proarrhythmic. Avoiding it by being aggressive with potassium replacement may have benefits. But using aggressive potassium replacement is a bit like Icarus flying too close to the sun because hyperkalemia is also hazardous. When I think of potassium replacement in patients with heart failure, I think of the nursery rhyme Goldilocks and the Three Bears. You want the potassium level to be just right, not too low and not too high. Say 4.7 is spot on. Now, POTCAST was an open-label, event-driven, randomized superiority trial conducted in Denmark. Patients had to have an ICD and a potassium less than 4.3 to be entered. Patients were then randomized in a 1-to-1 ratio to a treatment regimen aimed at increasing plasma potassium level to a high normal level, that was 4.5 to 5.0. Now, the way this was done was with potassium education about things in the diet that have potassium supplementation, or an MRA, or all of the above. The other group was standard Danish healthcare. There were about 600 patients in each arm, mean age 63 years, 80% males, and the median LVEF was 45%. The primary endpoint was a composite of sustained VT or appropriate ICD therapy, unplanned hospitalization for arrhythmia or heart failure, or death from any cause, and this was assessed in a time to first event analysis. The trial procedures are important to discuss. Patients in the active arm spend a number of weeks getting their potassium titrated up. There was a lot of healthcare interactions in these early weeks. This was done with information on increasing potassium in the diet, taking potassium supplements, and using MRA drugs, and again, measuring potassium quite often. I asked the investigators in the press conference if they were worried that patients in the active arm got more interactions throughout the trial, and their answer was that they spent the first few weeks getting the potassium regimen adjusted, but then it was really similar amount of healthcare interactions throughout the trial. From the supplement, combination therapy with an MRA plus potassium supplements increased from just 53 patients at baseline to 326 patients after up titration. And the potassium replacement group did indeed run higher potassium levels, but really not that much higher. Mean plasma K in the intervention group was 4.3 millimoles versus 4.0 in the control arm. Okay, now the results. In the high normal arm, 22.7% experienced the primary endpoint compared to 29.2% in the standard care. That's a 6.5% absolute risk reduction, NNT 15, and this translated to a 24% relative risk reduction, hazard ratio 0.76, with 95% confidence intervals going from 0.61 to 0.95. All components of the primary endpoint were directionally less in the high normal potassium group, Appropriate ICD therapies were 15.3 versus 20.3. Hospitalizations for any arrhythmia, 6.7 versus 10.7. Hospitalizations for heart failure were even less, 3.5 versus 5.5. And overall death was lower, 5.7 versus 6.8%. Safety signals were similar in both arms. In fact, an unplanned hospitalization lasting more than 24 hours or death from any cause occurred in 29.5% in the high normal potassium group versus 33.2% in the standard care group. That was a 12% reduction. The authors concluded, quote, among participants with any cardiovascular disease who had an ICD and were at high risk for ventricular arrhythmias, a treatment-induced increase in plasma potassium levels led to a significantly lower risk of appropriate ICD therapy, unplanned hospitalization for arrhythmia or heart failure, or death from any cause versus standard care. And my comments, the first thing to say is standard care in Denmark is quite strong. Access to care there is excellent, so beating standard care in Denmark is no small thing. The second thing to say is that it does not matter why the outcomes were better. The point of evidence-based medicine is not to discern mechanisms, but show whether or not an intervention works. Now, here, the benefit could have been because of greater use of MRAs. We know from TopCat and RALS and emphasis that MRA drugs confer benefit to patients with heart failure. It could have been the combination of MRA and potassium, or it could have been greater education on potassium levels in the diet. It could have even been simply avoiding low potassium. Again, it does not matter why. The fact remains that the results reveal a large, clinically meaningful reduction in a composite endpoint of bad things that can happen to ICD patients. And the statistical robustness here is decent. The p-value, which calculates the surprise value of the results given the assumption of no difference, was 0.01. The trial was powered to find a 28% reduction of the primary endpoint, and that was entirely within the 95% confidence intervals of the hazard ratio. But still, the upper bound of the hazard ratio is 0.95, approaching the zone of no effect. The main question, I think, is not the internal validity of this trial. I think this intervention in this setting did indeed lead to better clinical outcomes. I think the issue with POTCAST is the external validity of the trial. Can this regimen be replicated in other health systems? I mean, it's no small thing for me to even order an MRA drug. It's a ton of clicks in the electronic health record to make this happen. Then I have to make sure the patient comes back in for his labs in 2 weeks. Then there may be even more adjustments and more letters to the family doctor and more calls to the patient. It's no small thing to manipulate potassium levels in real-world practice. That said, though, if you do it as it is done in POTCAST, I think you can be confident you'll improve outcomes for your ICD patients, and that is a good thing to know. And overall, I have to say congratulations to the investigators who did this. This is a nice trial. And again, on the first day of ESC, I have some optimism about the research enterprise in cardiology. Now, I've gone on for a long time, longer than I would usually do, and there's going to be tons more to say about trials coming out at ESC. I'll have written essays on many of these trials. Take a look at the website, keep an eye on that. And of course, next week's podcast, I'll go over many of these trials as well. And if you're in Madrid, please do say hello. I'll be walking the hallways at the ESC Congress this weekend. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.